Now I would like to invite Dr. Saket Kant. This is our most awaited theme-based lecture. I would like to invite Dr. Saket Kant. He is a senior consultant endocrinologist, adult and pediatric in Max Super Specialty Hospital Shalimar Bagh and Pitampura. He is also a consultant in Action Balaji Medical and Cancer Institute, Delhi. He has done DM endocrine from IMS Banaras Hindu University. Over to you, sir.
All right. Thank you very much. Dr. Madhu Sureshan took me back to my PG days, whereas I was involved in the post-standard triglyceride metabolism. But I guess the tables have turned. The thesis was looking at pre-diabetes, NGT, and diabetes, and post-standard lipids, and now it's the other way around: post-standard triglyceride levels increasing the risk of pre-diabetes and diabetes. Nostalgic time, sir. Thank you very much.
Thank
So
you.
what I'll be Thank you, sir. So what I'll be taking you through is the master class where we'll have a discussion on the common myths, misconceptions, and the controversies in type 2 diabetes. In chronological order, I would like to invite all the panelists. Dr. B.M. Makkar is a diabetologist and pediatric physician, director, Dr. Makkar's Diabetes Service Center, ex-chairman RSSDI as member of the ACE committee. Dr. Rajeev Chawla is a senior diabetologist and director, Non-Clinic Diabetes Center, DNB teacher and guide for 20 years, more than 70 publications, macrovascular complications of diabetes, authored 7 books on diabetes, and Dr. Sanjay Kalra, sir, who is the past president of Endocrine Society of India, DM in Technology, FRCP. He's a visiting professor to AIMS Rishikesh, 225 original publication in peer-reviewed index journals, and 14 international, 38 national awards in the field of cardiovascular and metabolic research. He is the president of Asia Pacific Society of Hypertension Association of Physicians.
Saket, he isn't.
Is this?
He isn't.
Asia Pacific Society of Hypertension, Association of Physiologists of India, UP Diabetes Association, International Society of Medical Nutrition, and Secretary of the Journal Indian Society of Hypertension, Indian Society of Chronomedicine, and American College of Physicians, India chapter. So I invite everyone for a healthy discussion, and I'll be sharing my slides. So what I'll be taking you through, this is the disclaimer, that it's a universe in itself, so everything cannot be discussed. The most common mistakes, misconceptions, and controversies is what we'll try to address. So we'll start with Dr. B.M. Makkar. HbA1c for diagnosis. A lot of guidelines have started suggesting that you can use only an A1c for diagnosis. What do you think are the advantages and pitfalls of having only an HbA1c as diagnostic criteria for diabetes mellitus?
Good evening, everyone. Thank you, Saket, for involving me in this, master class. As we all know now, A1C has been, recommended as a test for diagnosis for almost now 5 years. When the first time it was recommended in the ADA clinical practice recommendations. But the caveat is that this is recommended as A1C, which is conforming to the NGSP standardization, and it has to be done according to that methodology and has to be standardized to that reference level. Now in India the situation is very, very different. We are getting this test done. Most of the non-standardized lab setups are there, especially the smaller cities and towns. The lab standardization is very poor, and the A1C, because it gives you an average, it can have issues in terms of diagnosis. So unless we are doing A1C from a very standardized lab, so it cannot be, there can be concerns regarding overdiagnosis or underdiagnosis. Second thing is, India is a country where there is very high prevalence of anemia.
Makkar, you got muted.
I was muted by the host.
Yeah.
So anyways, so because of the high prevalence of anemia, again, the issues relating to diagnosis can be difficult. Advantages are that this is, this is a point of care test. If you have, now we have technologies available where you are getting machines which are standardized to NGSP standards, and you can do a point of care test. Patient doesn't need to be fasting. Patient doesn't need to ingest glucose, and just finger prick test can tell you, A1C is above or normal, above the range to make diagnosis or in the range of pre-diagnosis. So one test can be sufficient. So it has plus points and minus points. But Indian setting, I think time is not ripe to adopt this as the diagnostic test. That is my take on this.
So it basically depends on whether the method is HPLC, boron affinity, or other standards. We have to be very careful. NGSP versus IFCC. More of people are shifting to IFCC throughout the world.
IFCC now, yes.
RBC turnover disorders would have problems, medication would have problems, and it cannot guide the short-term changes that we want. So probably an OGTT would still be more beneficial in our settings as compared to OGTT. That is what Dr. Makkar was trying to suggest.
I think,
So,
Saket, it is important to discuss here the common pitfalls with HbA1c. Sorry to interrupt you in between. In India, we have very common situation like anemia, B12, folic acid, iron deficiency anemias, hemoglobinopathies, hemolytic disorders, where HbA1c may be falsely low or high. Most common settings are anemia, where it is not very clear whether iron deficiency leads to a false high or a low HbA1c. Recently, I read one of paper from Dr. Madhu where they have corrected iron deficiency anemia, and that has led to correction of HbA1c also, because now it is thought that HbA1c may be falsely high also in anemia because of the fact that iron deficiency particularly, they have a longer span in terms of days. So
ABC lifespan is increased.
Yeah. So lifespan is increased, so they might have a false high HbA1c. Moment you correct iron deficiency, it gets low. So I think that is a very, very common situation other than hemoglobinopathies and hemolytic anemias and other things which are known to everyone. But common situation is that iron deficiency anemia, B12 folic acid, which is very common, may give very high false HbA1c. Then pregnancy again may change the situation. And Dr. Makkar very rightly said that, of course, even unfortunately, assays have not been yet standardized with HbA1c. Although metros, most of the labs are doing a good job.
in fact, in CKD also, when you have anemia and when the patient is on erythropoietin therapy, that also will change HbA1c a lot. And if you look at the KDIGO guidelines also, they still have a suggestion that you can use HbA1c as a good test in patients with CKD, which probably, I guess, is not true.
Yeah.
So coming to Dr. Chawla, gestational diabetes, you've got a lot of diagnostic criteria going on. So what is the best that should be done? More practical and that can be used GCT, 2R or a 3R OGTT.
Today, as per Ministry of Health, Government of India guidelines, we should go with the DIPSI guidelines. Unfortunately, I am serving as DIPSI president, so I will really vouch for a single test criteria of DIPSI, which is 75 gram glucose dissolved in roughly 250 to 300 ml of water, irrespective of your diet status, whether you are fasting, whether you are post-breakfast. And if your single value 2 hours more than 140, it is straightway taken as diagnosis of GDM. Because there is huge controversy. I'll not address to all the criteria. Either you go by IADPG criteria or O'Sullivan old criteria, all those criteria, or WHO extended oral JTT criteria. But in India now, Ministry of Health adopted a single criteria, that is you give only glucose and repeat 75 gram glucose and repeat sugar after 2 hours. You don't need to consider fasting sugar at all, because we know that in GDM diagnosis, it is postprandial hyperglycemia, which is much more relevant. So what tends to be an IGT in a non-pregnant female, any sugar which is more than 140 milligram is taken as IGT, we all know. So that should be read as single criteria for diagnosis of GDM, whether in first, second or third trimester. Again, there are differences when to do. All international guidelines still talk of 24 to 28 weeks typically, but we know in Indian ethnicity, we tend to get even GDM in first trimester at 13 and 14 weeks. So we say any degree of glucose intolerance, once your oral GTT 75 gram is more than 140, whether it is first trimester, second or third, it has to be read as GDM. If it is sugar is more than 200, that means it was a missed OHA or non-manifest OHA, non-manifest type 2 diabetes. So it is a pre-existing diabetes if it is picked up in first trimester. So anything between 120 to 140 also in the pregnancy is important, because that is a mild degree of glucose intolerance which happens in pregnancy. But if it is more than 140, it is clearly diagnostic of GDM.
So you'll be happy with an HbA1c in the first trimester itself, or the second, third trimester you will
No,
be happy
first
with
semester
HbA1c?
HbA1c, you only want to confirm whether it was a pre-existing diabetes, because the HbA1c will be classically normal if it is getting diagnosed in first trimester as GDM. That is what I said. Say if HbA1c is more than 6.5 and postprandial sugar is close to 200 or more than 200 milligram, that means patient was having a pre-existing type 2 diabetes which has not been diagnosed. Same way, if fasting is more than 126, then obviously it is not GDM. That means it is a pre-existing diabetes. Pre-GDM, what we can also label it as.
So your question, your answer basically answers the second question, that second part of the question that I was to ask. You have the cutout between 90 to 25 with various guidelines, 180, 153, 155 with the guidelines. If you look at two subjects, subject 1, subject 2, subject 1 has only one value, that is GDM. Other subject does not have any value, that is GDM, but has two values that are higher than subject 1. So you'll be classifying subject 1 as the GDM, but not the subject 2, according to these guidelines.
No,
And your
no. DIPSI even GDM. If it was 138, then I would have said that it is a impaired glucose tolerance or mild degree of impaired intolerance in pregnancy. If it is clearly more than 140, single value, only with single. IADPG still says that you follow 0, 1 and 2, 92, 180 and 155, two values more than that, it is suggestive of GDM, but we are going only with single criteria, 2 hours more than 140, it is state with GDM.
So DIPSI criteria do make more sense as far as treatment goals are concerned, because they're more aligned to the treatment goals that we have. Coming to Dr. Kalra sir, LADA Modi pancreatic secondary diabetes.
May I clarify here why you said something last statement, which is
Yes, sir.
important. Why we are going with you have a reason to ask why we are still going with a single criteria, because if you see the mean sugars in pregnancy, mean sugar fasting is 75, 74 milligram plus minus 10. 1 hour is 109 plus minus 10 or 11, and 2 hours is actually always less than 110 milligram. That is why any value 2 hours more than 120 is diagnostic of GDM, because in pregnancy mean values are not like what we see in otherwise in normal glucose tolerant patients.
Coming to Dr. Kalra sir, LADA, Modi, pancreatic and secondary diabetes. A lot of people say that they're rare causes of diabetes and there is no need to look for these type of diabetes. So why do we exactly need to know the cause of these rare causes of diabetes?
Thank you, Dr. Saket. That's an important question because number one, they are not so rare. If you look for them, you will find them and you will find them in plenty. Number two, they will actually impact the kind of investigations that you do, the kind of treatment that you give, and the kind of follow-up that is to be done. And if you understand the cause, it will help you decide the follow-up of the patient. Let's look at these examples one by one. In general, we tend to assume that everybody with adult diabetes, adult onset diabetes, is type 2 diabetes. And this may be true for 80 to 90% of all patients. But the other 10 to 20% are a huge minority in our clinics. LADA is autoimmune. Here you will have patients who have an autoimmune diabetes, which will worsen rapidly. Very soon they will need insulin. The kind of picture that you will see in Northwest India is relatively more handsome men, relatively more beautiful women, fair complexion, light colored hair, light colored eyes, beautiful eyes, less hirsute, both men and women, according to the ethnic group that they are coming from. No stigmata of metabolic syndrome, but there will be stigmata of autoimmune disease. You might find a malar rash. You can look for a goiter. There will be a history of arthralgia. You might even see arthritis. Look for vitiligo, you will find that. Even if you don't see all these, then there will be a history of thyroid disorder, a history perhaps of celiac disease. And all these put together will be a LADA phenotype. There will be normal weight, not obese, not overweight. In these, the medication, the change in medication is that you begin insulin early and you begin counseling about insulin. you can very confidently write the diagnosis. You do not even need to do the antibodies. If you want to do a confirmation, you can look for GAD antibodies. But do remember that antibodies will be positive in type 2 diabetes as well, in 1/3 of them. So just counsel the patient about the pathophysiology. Patient may not agree on day one, but after 1 or 2 or 3 visits, the patient will agree. Do try to explain to the patient. Sometimes when you say type 1 diabetes, patient is taken aback. So what I use in my practice is I tell them there is type 1 diabetes and there is type 2 diabetes. What you have is type 1.5. You are in the middle. There are some aspects suggestive of type 2, others of type 1.5. Let us treat as things come. And this brings us to another type of adult diabetes called type 1.5 diabetes. Type 1.5 can be of 2 types. We have just mentioned LADA first. Initially, you will diagnose type 2. Later on, it will turn out that it is autoimmune or type 1. The opposite is very common in Punjab and Haryana. The patient comes with an explosive onset. Patient comes in with the extreme hyperglycemia, with or without ketosis, with or without ketoacidosis. There will usually be an acute infection precipitating this, and you have to treat with insulin. You do it for a few weeks, and suddenly the glucose just resolves. Patient has come with an A1C of 10, 11, 12, 14, and after 6 weeks, you find that all you're giving is metformin and maybe 0.5 milligram of glimepiride, and not even that is causing hypoglycemia. This is also type 1.5. In the literature, it is described as flatbush diabetes. Here, the phenotype will be typical Indian phenotype, relatively dark complexion, more hirsute men and women, maybe balding, androgynous balding, and all the stigmata of metabolic syndrome. So here, again, it is good to know the diagnosis because you can follow up. Many times it is possible that we burn our fingers. So if you're not sure, you just tell your patient that we have diagnosed diabetes. This is a cross-sectional diagnosis. But the type of diabetes, this is going to be a longitudinal diagnosis. So bear with us. We will treat as and when each and every turn and curve comes in the journey. MODI is different. This is also fairly common. The classic presentation is 3 generations coming to you with diabetes. But now, Dr. Makkar and Dr. Chawla will agree, if you've spent 3 decades in practice, as it is, you have many type 2 diabetes and many type 1 diabetes families also coming to you with 3 generations. So every 3 generations presenting don't have MODI, but still keep that in mind. You will have relatively less severe hyperglycemia, good response to sulfonylureas. And it is said that complications are less, but still that should not prevent us from doing aggressive treatment and proper treatment. From a general practice point of view, use the same drugs that you would use in type 2 diabetes, but sulfonylureas will give you good results, better results. Pancreatic diabetes is important. Here, there is a destruction of both the alpha and the beta cell. So if the alpha cell is lost, glucagon reserve is less. You have lost one counter regulation. That means patient is at risk of hypoglycemia. Treatment of choice would be insulin. Do not use GLP-1RA or DPP-4 inhibitor. And when you're using insulin, it would be a good idea to use small, frequent doses. Insulin analogs will be preferred because they cause less hypoglycemia. And while you're treating the patient, be mindful of the fact that you have to explain hypoglycemia awareness and recognition to the patient. Also in pancreatic diabetes, there will be exocrine dysfunction. So take a good history. There might be steatoria. Investigate if required. And if necessary, you treat with the pancreatic enzyme supplementation. So these are some of the common causes. Secondary diabetes has gone up markedly this year, and that is post-steroid dysglycemia. And I'm sure we are all aware of the impact of steroids on metabolic health. There is a case for steroid stewardship. The same way we all speak in medicine about antibiotic stewardship, we should campaign for steroid stewardship within our specialty and also within associated specialties so that we are able to minimize the impact of steroid-induced diabetes.
So a proper diagnosis, I guess, would entail proper treatment. It would also provide prognostic data. You may have higher risk of pancreatic cancers and pancreatic diabetes. Will entail familial screening if you have something suspicion of MODI. Additional defects in MODI, if you have MODI 1, MODI 5, you'll have to look for additional defects also. And a rare cause, maybe a rare cause, but it is the diagnosis for the infected patient, and would, if you can make a diagnosis for that patient, would entail a proper treatment for that patient. Coming to a very important part, diet and diabetes, I will start with Dr. Makkar. What are these low and very low calorie diets that have been propagated a lot? what impact do they have on glycemic control and other parameters of patients who have diabetes?
Uh, Very important, question. And as we all know, lifestyle interventions are cornerstone of diabetes management, whether it is type 2 or type 1. Type 1, they are important because most of the time we need to match the intake of calories with the amount of insulin that is required, and the timing of food and the insulin dosing. uh, for type 2, they are again very important because most of the type 2 diabetes in India have overweight or obesity, and modest weight reduction is advisable for most of the patients with type 2 diabetes. That is where there is a lot of myths about diabetes diet, which are in which impact the treatment of diabetes. And there are a lot of fancy diets or diet fads that come into picture. So as for the low and very low calorie diets are concerned, most of the type 2 diabetes patients who are overweight, a low calorie diet is can be recommended. But one thing, first thing is that we should know what is a low calorie diet and what is a very low calorie diet. So low calorie diet only means that you reduce the daily intake of calories by about 400 to 500 calories from the recommended dietary intake. And when we talk of very low calorie diets, that means we go on drastic reduction of calories, and we are providing only about 800 calories per day of the caloric intake as per the requirement of the individual. With both these diets, we have to make sure that we are providing adequate protein, adequate nutrition in terms of minerals, vitamins, and other micronutrient intake. Now, these diets have come more into discussion after the study that we have got from Roy Taylor in terms of direct trial, where VLCD has been used to uh, give remission of diabetes. So I think that is a very important study, and it has for the first time shown that even in primary care practice, if you know put lifestyle interventions in place and follow them up aggressively, you can lead to a significant impact on diabetes or even cause remission of diabetes. So they are important, but they need to be low calorie diets are actually recommended for most of the people with type 2 diabetes should be recommended because most of the people are overweight or obese, and we have to try to achieve a weight reduction of about 5 to 7%. That will improve the metabolic picture in most of the type 2 diabetes patients. But very low calorie diets, yes, they can be advised, especially for those people who can be candidate for remission of diabetes. But another important thing is VLCDs have to be given under medical supervision because there can be issues relating to electrolyte imbalance, severe, marked increase in triglyceride levels, and acute pancreatitis episodes can be complications.
Dr. Chawla, a lot of patients come to us, they've read on the internet, a high fructose diet is very beneficial for patients with type 2 diabetes. What is your opinion? What is exactly high fructose
If
diet?
you
What is
if
the
you if you very straightforward ask me, all of us as clinician, we if at all we either suggest a low calorie or a very low calorie diet, what Dr. Makkar very rightly said, in an attempt to either put obese patient and type 2 diabetes into remission, or what we used to earlier say a reversal of diabetes, which has been now changed to sort of remission of diabetes. These fancy diet patterns, whether you talk about how high fructose diet or keto diets, I think these are like changing fashion every month, and these are more like a product of WhatsApp University. As clinician, we advocate only a very balanced diet. We tend to calculate the energy which patient is going to burn, which patient is going to take based on the lifestyle of that patient. If patient is say burning 300 to 500 calories every day, I'll be still happy giving 1600, 1700 calories. Someone who is very, very sedentary lifestyle, he is not doing too much of exercise, I'll be happy giving maybe 12 to 1300 kilocalories of diet. But then it has to be a very right mixture of protein, fat as well as carbohydrate, where carbohydrate we should restrict close to 55 to max 60%, that too in a roughage form, in crude carbohydrate form, not to promote the intake of carbs which are straightway going to add to the calories, which are fine carbohydrates. We should attempt at least 15 to 20% of protein intake and not more than 10 to 15% of fat intake. That also in the right composition of MUFA and PUFA, and with changing and blending pattern of oil. I think as a clinician, I'll suggest that it is better to adhere to a scientific diet pattern rather than being on high fructose diet or Atkins diet or keto diet or intermittent fasting diets. I'm not in favor
So
of that.
Saket,
Sanjay, what do you say?
I would like to comment here. First thing is that we have to keep in mind that it is not first time that we are getting something like high fructose diet or some. This particular high fructose diet has come into discussion largely in last 3 to 4 years because of some self-style diabetes cure promoting people showing you a test strip dipped in the juice and showing that there is no increase in the sugar levels. So first thing is we have to keep in mind that fructose is a simple carbohydrate. It's a monosaccharide. It is not a disaccharide. It is worse than dextrose, the common sugar, which is a disaccharide which needs to be broken before absorption. Fructose is directly absorbed. It is fruit sugar. Second thing is all diets that are containing glucose or any sugar in liquid form are bound to give you a faster or higher glycemic peak and require a higher excretion of insulin as compared to the complex sugars, as Dr. Chawla mentioned, that most of the time we should advise carbs coming from the natural whole grains or natural fruits or vegetables rather than the refined forms. And the another important thing is there have been a lot of diets, whether it is high carb diet, low carb diet, high protein, low protein, high fat, low fat. At the end of day, there is enough data to show that what matters is the total caloric intake over a period of time that decides how you are going to be impacted by the diet. It is not just whether you are taking high carb or low carb. Only thing is, if you have adequate protein in diet, in fact, if you look at the recommendations from Jocelyn Center, they recommend a higher protein diet. They recommend 30% protein in diabetic diet also, and they have enough data to show that if you are giving more protein diet, actually you induce more insulin secretion and you have lesser, glucose excursion in patients who are following these diets. So all fat diets, I think, should be avoided. And now we can have Sanjay's comment.
Best is we should adhere to a very, very balanced diet, which can be sort of adopted by the patient and becomes a lifestyle. Not for 3 months you give an Atkins diet, then you give a keto diet, then you give a intermittent fasting diet pattern. I think a balanced diet probably will go a long way in achieving the targets.
We can have Sanjay's comments. I
Sanjay,
interrupted.
your
Sorry,
comment.
Sanjay.
Balanced diet is what is required. Of course, there is a lot of marketing behind all these fancy names, like both Dr. Makkar and Dr. Chawla has said. Let's look at things from a general perspective. If you're a normal human being, you are trying to achieve good health, you are trying to control diabetes, control weight, you're a balanced personality, you're aiming for balanced growth, then you will follow a balanced diet. And what Dr. Makkar said is correct. You just reduce the total number of calories, you increase the total expenditure, and things should be fine. But supposing you are an elite athlete, maybe you want to win a gold medal in boxing, you want to build a gold medal in weightlifting or in cycling. Now here you are not aiming for a balanced physique. In some sport, you might want more of upper limb muscle. In another sport, you want might more of lower limb muscle. In gymnastics, you would want to be lean and thin. You shouldn't have even an extra gram of fat on your body. Then this concept of body composition will come in. Then the issues regarding how much of protein to take, how much of carbohydrate to take, how much of fat, all these will come in. Maybe a weightlifter or a sumo wrestler would want a 50% fat diet. I do not know, but certainly the fat percentage will be more there. So then these issues come in. But for all of those who are listening to us and for all those whom we treat, what Dr. Makkar and what Dr. Chawla has said is right. Follow a balanced diet and try to restrict calories as much as possible without causing malnutrition to yourself. Ensure that you do not have macro or micronutrient malnutrition.
Deficiencies, yeah.
In India, we do not have any issue related to food security. This is an issue in many South American and African countries. But we do have an issue related to protein security. Many of us have protein deficiency. And in your clinics, you will find so many people with mild edema, not pedal edema maybe, but edema over the tibia, over the shin. And that is actually a form of adult kwashiorkor. It is because of too little protein. You put the patient on a high protein diet and that edema will resolve.
Especially in vegetarians, it is very common.
Yes.
In fact, a high fructose diet has been shown to have discordant effects on glycemia and the triglycerides, increases triglycerides, although improves glycemia. So a lot of patients who come to our clinics on a high fructose diet because they've read a lot on Google, they have to be refrained from using that high fructose diet. So in the interest of time, I'll come to the important part of the discussion, oral anti-diabetes drugs. I'll come to Dr. Sanjay Kalra. Metformin we were using for a very long time. We have huge experience with metformin. Cardiologists are starting to challenge metformin because they say that there is no CVOT, no cardiovascular safety data of metformin. And in fact, the guidelines also have started challenging metformin as a first-line therapy. What is your opinion regarding that?
Metformin will remain a first-line therapy, though other drugs might come alongside it. When we were students, the first-line therapy for type 2 diabetes was lifestyle modification. And you try it for 3 months. After that, you begin metformin. Then a few years ago, the guidelines changed, and what I read was lifestyle modification and metformin. In one breath, this is first line. And now a couple of years ago, I read, and the guidelines have changed. Now the first line therapy is metformin and lifestyle modification. That is how it is written. So metformin will remain a first line therapy. In some subsets, there might be other first line therapies like SGLT2 inhibitors or GLP-1 agonists.
That depends on overall profile of the patient. Metformin definitely remains the first line option because it addresses the core issue, which is insulin resistance, both in adipose tissue and muscles, primarily into liver, but also to some extent periphery also. And recent consensus, fortunately, me, Makkar, Dr. Sanjay are there. You were also part of that RSSG Endocrine Society. We reviewed the whole literature in 2020, and we finally said that metformin has to be first line option along with lifestyle modification. Given circumstances, someone having atherosclerotic cardiovascular disease, strong evidence of diabetic nephropathy, heart failure predisposition, they can be on additionally on SGLT2 or GLP-1 analog. I don't think till now there is a question that metformin should not be first line option.
Coming to Dr. Makkar, newer drugs, DPP4, SGLT2, GLP-1 receptor agonist, starting pushing sulfonylureas down the ladder. So they say it is beta cell apoptosis, glenite also. What is your experience and what is the evidence here regarding?
I think, we are living in the era of evidence-based medicine. So my experience or Dr. Chawla's or yours or Sanjay's experience is not the only thing that is going to decide this issue. There used to be, there were some issues relating to the increased risk of, or the risk of beta cell apoptosis and secondary failure to sulfonylureas based on some experimental data. But I think now we have enough studies to show that there is sulfonylureas do not cause apoptosis or beta cell failure. Beta cell failure is the part of natural progression of type 2 diabetes. There may be some agents which were supposed to, kind of slow down the beta cell failure, and we got the initial experimental data from GLP-1 receptor agonists and DPP4 inhibitors. But look at the clinical trial data comparing metformin plus DPP4 inhibitors or metformin plus SGLT2 inhibitors. Now we have 4-year follow-up data comparing metformin, DPP4 inhibitors and metformin SGLT2 inhibitors with metformin sulfonylureas. And at the end of 4 years, there is no difference in the A1C reduction. So that means clearly that there is no enhancement of beta cell failure. Now then we have, very important trial, Carolina, which compared linagliptin metformin combination with glimepiride metformin combination. At the end of clinical trial, no increase in the cardiovascular risk in sulfonylurea arm, no increase in, no difference in the A1C achieved in the two arms. Finally, we have the data from GREAT trial, which was presented just now at the ADA. Look at the outcomes. In fact, the fastest failure happened in the sitagliptin arm, followed by the sulfonylurea. So modern sulfonylureas or the recent new generation sulfonylureas, I don't see there is any reason to now believe that they cause apoptosis or they lead to secondary failure of therapy.
So probably they are very potent drugs, decrease glucotoxicity, lipotoxicity very quickly, and in fact may be beneficial in patients who've got very high glucose
Absolutely.
levels, and decreasing glucotoxicity may improve beta cell function also.
Yes.
So coming to Dr. Chawla, a lot of physicians ask us, how do you basically have a combination of sulfonylurea plus insulin, whether it's a basal plus basal bolus or a premixed insulin? Whenever you want to start, what do you do with the secretagogues?
I think earlier days we were talking about BIDS therapy that used to be bedtime insulin, daytime sulfonylurea when we were using conventional sulfonylurea, and that time it used to be an NPH. But now definitely, even if these days when we are using glimepiride like drug or glycoside modified release drug, which we are using either once and twice daily, and if for fixing fasting sugar, if we add a long-acting basal analog either by like Glargine or maybe Degludec, it makes huge sense because you are able to fix fasting very well. And for daytime postprandial excursion, we are using sulfonylurea. And advantage of using sulfonylurea with basal insulin will be that through sulfonylurea, you are going to have a portal release of insulin. So that adds to, I think, in a more physiological way, addresses the issue of insulin resistance into the liver also, which probably cannot be addressed by giving exogenous insulin in total. If you are going straight on premix insulin or total insulin substitution, weight gain is going to be much more. I agree with sulfonylurea and insulin also, there could be little increase in weight as compared to only being on sulfonylurea. So you need to gradually titrate the doses, not using very high doses of sulfonylurea. Use an optimum dose of sulfonylurea, metformin, maybe even DPP-4 can be continued. And with basal insulin, that makes huge sense because fasting gets very well corrected with basal insulin and postprandial excursions get very well corrected with sulfonylureas and metformin.
In fact, another advantage would be the paracrine action of insulin secretion in the beta cell that could decrease glucagon from the alpha cells.
Yeah.
That would also be beneficial. That would not be there with exogenous insulin. Two questions to Dr. Kalra. Use of two different sulfonylurea. We see a lot of prescriptions coming up. Two different sulfonylurea in the same prescription, a sulfonylurea with a glenide or a concomitant DPP-4 GLP-1 receptor agonist. How do you look at that?
We should avoid that. There's no rationale, and there is no need to give two SUs together or an SU and a glenide together. So that is an absolute no. Don't do that in practice. If you wish to add two secretagogues, one can be a sulfonylurea, the other one can be the indirectly acting secretagogue, which would be a DPP-4 inhibitor. Or you can give GLP-1RA along with sulfonylurea.
So DPP-4, GLP-1.
Sanjay, you are being very modest. Your message should be very loud as a ESI president that two sulfonylurea prescribed together should be taken as a
it's an absolute no. Yeah, there is no way to
absolutely no. It should not be mildly passed because unfortunately many physicians we find even in Delhi doing the same thing. Morning, evening glimepiride, glycoside added in between short acting or maybe non-sulfonylurea secretagogue, which should not be done at all. I think a strong message has to go that two sulfonylureas, two secretagogues should not be there because we are doing more harm than doing any benefit.
Another important type of prescription that I come to see often is premix insulin twice daily and a dose of Glargine or Degludec in the afternoon.
Unfortunately, yeah.
Which is not part of this questionnaire, but I think that is one practice that we see off and on, and again needs to be totally, taken off.
A GLP-1 DPP-4 also would not make much sense because the GLP-1 receptor agonists that we have, they are resistant to degradation by DPP-4. So that also does not make sense. But
in any case, you are using supraphysiological dose. You are using pharmacology dose. So endogenous is not going to be
no point combining GLP with DPP-4. Makes no sense. Yeah.
Coming back to Dr. Makkar, so the EGFR indications for SGLT2 have been dropping and dropping. We have the DAPA-CKD trial wherein they have used up to 25. do you think this EGFR indication may just go away with SGLT2 inhibitors, and you may not derive the glycemic benefits from SGLT2, but you will still derive the extra glycemic clear trough benefit with the SGLT2 inhibitors?
So if we look at the trajectory of data that has emerged over last, about a decade now, because the first data came from Empareg way back in 2015 or so.
15.
So, and we started seeing the renal benefits, and the more and more studies became, aggressive with the cutoffs at 30. I think there'll be two subset of usage of SGLT2 inhibitors. One is for the control of glycemia, where all patients with type 2 diabetes and of course CV benefit, there'll be use of SGLT2 inhibitors. And the second subset will be with or without diabetes, but having CKD. And how low we can go, I think we will see in forthcoming trials. But
I think heart failure trials, both DEPA heart failure, they have used till 30, and Emperor Reduce has used till 25. So I'm sure
so even
we can
so
safely
25
use now
is
till 25
So,
off label
but I'm
also.
sure they are going
Not for
to,
glycemic benefits, because reduction may be very low, like 0.4 only, but for extra glycemic benefits like checking CV death and hospitalization with heart failure, even progression of CKD will be much reduced if we have used SGLT2 till EGFR 25.
So another
I think till
important thing to
25 we
keep in
can
mind
safely
now
use.
is
Is
with
cut out.
the understanding that there is phenomenal CV benefit with SGLT2 inhibitors and phenomenal renal benefit.
Renal benefits, yeah.
And these are the conditions where most of the patients end up in hospital in acute emergencies. So now already we have DARE trial data where the DAPA was used in hospitalized COVID patients, did not show any increase in risk. In fact, shows strong trend towards benefit in reducing cardiovascular as well as renal outcomes. So I think somebody is going to test the bottom further and go till a EGFR of 15 also to test
15
these
most
agents.
likely, yeah.
Once this is tested, then except for ESRD, I think these agents should be recommended for use.
In fact,
That is my
patients
take on this.
Yeah, in fact, patients with CKD die more of cardiovascular disease as compared to
Yeah.
CKD now. So
Do
will make more
remember,
sense.
but Dr. Saket, we should remember that the patient is much more than an EGFR number.
Yeah.
Before you check the EGFR, look at the patient clinically.
Overall.
Your patient should be taking enough water.
Yes.
Your patient should be eating enough food. Your patient should be eating enough carbohydrate. If there is fluid deficiency or there is carbohydrate deficiency, certainly you are going to land in ketosis. So before you look at the EGFR, make sure that your patient is hemodynamically stable and is gastrointestinally stable. Patient should be able to take enough water and carbohydrate and should be able to absorb that as well. If your patient is already vomiting or patient complains of loss of appetite and is barely able to eat 2 chapatis in a day, that is not a candidate for SGLT2.
No, any condition with hemodynamic decompensation is a contraindication for, I think, all oral agents, and only insulin remains the therapy. But once the patient is compensated state, I think we are going to see more studies coming in, even more of contraindicated situations. And let us see how the data emerges. We are always learning. We are in the phase of learning.
Dr. Sanjay very rightly said, we need to have overall approach and holistic approach on the patient, not only based on EGFR or creatinine. You need to have a total sum profile of the patient which needs to be considered. Very true.
So another very important thing, we'll want a very strong statement from Dr. Sanjay Kalra on this. Sliding scale for management of hyperglycemia. Very commonly used. Even if you try to correct that, they're still going back to the sliding scale insulin. So I guess a very, very strong statement on this.
A strong statement, and taking the cue from Dr. Chawla, a very strong statement. This is not to be used. I cannot think of anything. I myself work in a resource limited setting, and I do not use sliding scale. I cannot imagine any situation where a physician in modern India should use sliding scale. A few simple things to remember. Just let us forget the word sliding scale. If your patient is in the ICU, we will use intravenous insulin. If your patient is in the ward admitted, then we will use subcutaneous insulin. If it is intravenous, you will use an insulin pump. Supposing an insulin pump is not available, you can use a GIK. You just put up a 500 ml bottle of 5% dextrose and you put insulin in that. In the ward, we are using subcutaneous insulin. patient should be able to eat adequately, then it will be basal bolus. Suppose for whatever reason patient is not taking 3 meals a day, you can always give basal plus. Suppose with that glucose is not controlled, you add a concept of correction dose. So I did a pre-lunch, I gave maybe 8 units of regular insulin. I did a post-lunch and glucose is 500. I can always give a correction dose. There are values to calculate that. Usually they are used in type 1 diabetes. We don't use them in adults or type 2 diabetes, but you can always add 4 or 6 units at that time. And that should help us sail through. With sliding scale, we are always, it is like a dog running after its own tail. The speed may be there, but the velocity is going to be in minus. So when you're in physics, you learn the difference between speed and velocity. Sliding scale is a very speedy scale, but the velocity goes in negative.
So it is basically irrational. It's a roller coaster effect, increasing glycemic variability. Basal insulin usually is missing, which is the important component. Does not take into account the BMI, insulin sensitivity, patient accepting orally or not, the carbohydrate content of the meal. There is no calculation of nutritional correction doses. So basically, ignorance is bliss for someone who is prescribing insulin. It is reactive, not physiological insulin therapy, and we should have a proactive approach to maintain euglycemia. We should not basically run after hyperglycemia. We have to prevent hyperglycemia or hypoglycemia. That is the target that we have in mind. And we need a structured insulin regimen with correctional doses. That is way better than just putting up a sliding scale. So coming to Dr. Rajeev Chawla, analogs versus conventional insulin. Cost involved, analogs are much higher cost than conventional insulin. What is the efficacy and how do you see, how do you choose between these two?
Dr. Saket, Kant, you'll agree with me, while we are practicing in metros, using analogs still makes sense in most of our patients because of the fact that we want more flexibility. Our patients many a time may not comply to that 30 minutes to be given prior to the meals because of their irregular eating habits and all that. And of course, we know many times if you are having an executive lifestyle, you may miss your lunch or evening snack you may not be able to take. So that delayed postprandial pre-dinner hypoglycemia is more with conventional insulin. While you're using analogs, these are little shorter acting. They give you flexibility in terms of taking, whether you are going to take it immediately meals, before meals, or you can even take it after meals also. But I will say that in terms of overall HbA1c correction, there have been many meta-analyses saying that analogs don't score over conventional insulin. Only thing is risk of hypos are less and it gives you more flexibility in terms of dosing and timing of otherwise conventional insulins at places where patient cannot afford it, they are equally good in terms of getting HbA1c correction.
So efficacy is both the same, but convenience probably more with analog insulins. Coming to Dr. Makkar, we've seen a lot of prescriptions, mixed insulin 3 times a day, a 30-70 2 times a day, or a 50-50 once, or a 30-70 3 times a day. How do you compare this with a basal bolus regimen? Which one do you think is superior?
So, if once we are saying mix insulin 3 times a day, I would presume that this is mix analog 3 times a day. If it is pre-mix conventional insulin, it doesn't make sense because there is markedly increased risk of hypoglycemia as the regular component has a much longer half-life. Even if you are using it twice actually, so there is a period of over insulinization before the next meal where the risk of hypoglycemia is higher, and that is why we have been advocating mid-meal snacks for all those patients. As for the premix analog is concerned, we have clinical studies also showing that they can be used 3 times, starting with the 1 dose or 2 dosage, and maybe adding a third one before lunch, and you can have comparable reduction in terms of A1C or the glucose levels compared to basal bolus. Now, in the what I'm going to share here is something which is very practical experience that I thought of in the current COVID setting. When we are making use of basal bolus, the basal titration needs time. You need 3 to 4 days time to up titrate basal. You can't keep on up titrating every day because of the longer half life. But this is the this is the closest to the physiological approach to insulin therapy. But in setting of COVID, where the people suddenly came presented with very high sugar levels, it was easier to use something like premix 50-50 to target postprandial and the fasting side by side, because even the longer acting component in premix analogs has much shorter half-life as compared to glargine or regludac. So those kind of settings, I think this concept helped. I felt it was much more helpful than going for a basal bolus therapy or starting with the premix conventional. But
So
yes, there is data supporting use of 3 doses of premix
Earlier days we had
analog.
Novomix 1, 2, 3 study, which
Yeah,
told us that
Novomix
you could
1,
use
2, 3 studies. This
you could
study which
use 3 doses.
yeah
But I think in the current scenario, especially COVID scenario, we have seen those patients, as Dr. Makkar is rightly saying, those who have been morning steroid doses, we have been
yeah
able to use 50-50 at breakfast, maybe at lunch also, and followed by 25-75 dose at dinner, before
yeah.
dinner. Or otherwise, you continue with your premix and give a prandial insulin dose
Yeah.
at lunch, which becomes little more
But
physiological.
for other cases, if you are targeting good glycemic control, basal bolus remains the closest
Ideal,
to
of course,
the
most physiological.
or you can say this is the regime which offers something short of pump. This is the best option.
Most physiological, yeah.
so a
Sanjay, you
mixed
want to
insulin.
share something here? Dr. Sanjay, your
So yeah, I
experience
think
on
it's a complete
steroids and
discussion. Yeah.
So a mixed.
Don't hesitate to use basal bolus insulin.
Yes.
If your patient is responding well to 1 dose or 2 doses per day, that's good. And the patient doesn't think in terms of premixed or basal bolus. For the patient, the classification is 1 injection, 2 injections, 3 injections.
very
Suppose
true.
you are not able to control glucose and you have kept on increasing the dose. You've reached maybe 0.5 units per kg per day. Then it is time to think, am I using the right regimen or not? Instead of
Absolutely.
increasing the number of units, we might use the same number of units in
2 divided
more doses, more divisions.
dose.
There can be different ways of using 3 injections per day, especially for school children. A child goes to school, he will leave school at around 6:30 a.m. to go by bus. We'll reach school, have a snack there, and maybe we'll reach home for a lunch after by 3 p.m. or so. If you give a rapid acting insulin, especially a rapid acting insulin analog, that is not going to last for such a long time. So a good idea might be premixed in the morning before the child leaves home, rapid acting or regular insulin at lunchtime, and again premixed at night. I would not recommend this as routine therapy, but this is something that you can use 3 injections per day. And we are talking of school children, but also adults, people who leave home early to go to work, who are not able to have a proper tiffin at work and to come back late in the evening for lunch. This triple dose can work. Another 3 dose might be regular in the morning, regular in the evening, and a premixed at night, a co-formulation at night. That will work in some situations. And do not hesitate to move on to basal bolus for a short period of time if you're not able to achieve control. Tell your patient, let us increase the gear. We'll change the gear. We are trying to climb the mountain. In 10-15 days, your glucose will be fine. Then patient will say, Doctor, this basal insulin that you're giving me at night, this is very expensive. So we just take 1 or 2 pens, and when your glucose level comes down, we'll be able to count the total dose requirement, and we'll be able to bring you back to premix twice a day. This will work in many patients with type 2 diabetes.
In fact, a premixed insulin given 3 times a day, you are having 6 peaks. You have to manage 6 peaks, and a basal bolus would entail just about 3 boluses, or in fact 4 boluses in some patients. So that would be 3 or 4 peaks only. So it is easier to manage 3 or 4 peaks as compared to managing the 6 peaks, which are basically overlapping also if you're using 30-70 or 50-53 times a day. Dr. Kalra, concentrated insulins, got a lot of concentrated insulin now. So which, when, and why would you give to your patient?
Remember that first of all, we should decide our insulin regimen. Once you've decided that in conjunction with your patient, then you decide the insulin preparation, whether you want to give human or analog, first generation or second generation analog, and then you decide the concentration. Regarding rapid acting insulins, we have Lispro 100 and Lispro 200. Lispro 200 will be indicated if the daily dose requirement is higher, because you will be able to use more insulin in a lesser volume, and you will be able to do justice to the pen, which has got 600 units. If the daily dose requirement is less than 20 units, then the lower concentration, 100 units per ml, will be fine. The PKPD is same for Lispro 100 and 200. On the other hand, when you look at glargine 100 as compared to glargine 300, the pharmacokinetics changes. So when will we use more of U300 glargine? The glycemic variability is less with this particular preparation. So if you have people who are coming in with difficult to control diabetes, variable diabetes, someday the fasting is 150, the other day the fasting is just 80, and patient swears that she ate the same food, did the same exercise, slept the same way, and still glucose is not stabilizing, then we might consider a shift to U300. If patient has high incidence of hypoglycemia, especially nocturnal hypoglycemia, on the lower concentration, U300, then again U300 is a good option to use. And also, like we mentioned for Lispro, if the daily dose requirement is very high, maybe 30, 40, 50 units of glargine per day, then it would make sense to shift to U300 because the volume of injection will be lower and there will be less discomfort.
All right, I'll get back to the last question in the interest of time. Reversal or remission of type 2 diabetes, is it basically look up Google search and you can see all sort of things coming up on Google, patients coming to you with all sorts of ideas that they can reverse their diabetes or go into remission. So what is your opinion? I'll take a quick opinion from everyone. Opinion, please, on reversal remission of type 2 diabetes.
So Dr. Chawla just left. I think there was some emergency call. See, remission of type 2 diabetes has come more into limelight, as I just mentioned, after the direct trial. But the first data for remission of diabetes came from actually the bariatric surgery. All bariatric surgery patients, there was a large large study from Walter Pori's group showing that post bariatric surgery, there is immediate reduction in the glucose levels, even before there is a significant weight loss. And that was the time when we started thinking of the foregut and hindgut hypothesis and so on. And then we came out with a lot of studies from Roy Taylor's group. And finally, we had direct trial and we have 2 years follow-up of that also, showing that remission of type 2 diabetes is possible. One, the studies have been done in subsets of patients with different duration of diabetes, and what data suggests is that if the duration of diabetes is less than 5 to 6 years, the chances of remissions are much higher as compared to those who have duration of diabetes more than 5 to 6 years. Then this can be achieved both in bariatric surgery groups. There is a lot of data. Stampede trial was one of the important trials. Then we have data from SOS follow-up studies, and other groups also have shown same thing. Direct trial has shown the impact of aggressive lifestyle interventions using VLCD to lead to remission of diabetes in primary care setting, which is interesting because you are not banking here on bariatric surgery, you are not banking here on specialized care. It is the primary care setting where you are targeting remission of type 2 diabetes. And I think this is a worthwhile approach for trying in all new detected diabetes patients, particularly in Indian setting, because we get diabetes almost 10 to 20 years earlier as compared to Western counterparts. We have longer duration of diabetes to live towards the second half of life, and the longer is the duration of diabetes, the higher the risk of complication. So should be attempted, but should be attempted according to the evidence-based medicine and not based on the whatever recommendations are coming from self-styled people or those touting cure for diabetes or those all kind of internet universities. That is my take on this.
A final comment from Dr. Kalra, sir, before I hand it over to the organizers.
Diabetes remission is possible in some patients. Do not use the word reversal. And remember that this is valid only for type 2 diabetes, yes, not for type 1 or LADA or pancreatic diabetes. There is an ABCD formula by Lee et al., which tells you in which patients diabetes remission is possible or where is more feasible. A for age of the patient, if the age is less. B for BMI, if the body mass index is more. And finally, the patient is able to bring the weight down. C is for C-peptide, if the C-peptide is high. We do not need to do a C-peptide in every patient. You do not need to do it in any patient actually. But C-peptide high means that patient has insulin resistance, does not have a secretory defect. And D is for duration of diabetes. If the duration of diabetes is less, patient has come to you with recent onset dysglycemia. To this ABCDE, we add an E. E for is enthusiasm and energy of the patient. If the patient is enthusiastic, is energetic, patient says, yes, I will do what it takes. I will change my lifestyle. E is also for expertise and education of the doctor. So we should also improve our expertise. We should keep on improving our knowledge all the time. If you have a patient who is a good fit for probable remission, then we will avoid using secretagogues. We will use drugs which are more geared towards reducing glucotoxicity and reducing weight. Use high-dose metformin, GLP-1 receptor agonists, and also SGLT2 inhibitors. Bring the glucose down, and you might be pleasantly surprised. But remind your patient and the family about the definition of remission. Remission doesn't mean just achieving good HbA1c control and maintaining it for X period of time. The definition of remission now is, and this is an Indian definition which is accepted globally, achieving normoglycemia, maintaining it for a specific period of time without having causes like renal impairment or hepatic impairment or maybe hypothyroidism, which are causing low glucose values. So you want normoglycemia, but you don't want it because you have got renal impairment or CKD. So that should be explained to the patient.
So in fact, the glycemia may go into remission, but the complications may not go into remission.
Yes, they will worsen.
Because you may have formation of advanced ligation products that are irreversible. Thank you very much for the discussion. I hand it over to the organizers. Thank you very much.
Thank you.
And thank you, Dr. Saket, for moderating, and thank you all the panelists for making justice to this topic. And like I was just thinking about the Olympics. If we have the Olympics of diabetes, then whether it is the number of patients or whether it is the quality of patients or quality of study or quality of the faculty, then certainly India will get a gold in the Olympics of diabetes. Though, as Dr. Sanjay Kalra has mentioned, PV Sandhu has already got a bronze. And one thing to add upon, in hockey, we have already reached the semi-finals. Thank you everyone.